If you're getting ready to take the CPC exam and thinking to yourself, gosh, I wish I could just watch someone else go through some of these cases to see if I'm doing this the right way, well, you're in luck because today we're going to go through some sample cases, things that are similar to what you might see on the CPC exam. If you're new here, I am Victoria. I'm a medical coder, auditor, educator, and content creator, and I have been in this industry for over 15 years. And my favorite thing is helping people like you pass your certification exams or just feel more confident, more strong, more well informed in the medical coding industry. So you definitely want to make sure that you subscribe and hit the notification bell so that you can get alerts when I post new episodes. So just a quick refresher, the CPC exam is 100 questions. You will have 4 hours to complete it. It is an open book exam. You are allowed to take your code books, your CPT, your HCPCS, your ICD-10 CM, check with the AAPC on the regulations of which versions you're allowed to take. Typically, it's any version of ICD-10, any version of HCPCS, but you need to have the AMA edition of the CPT book. So those are the books you are allowed to take. You are not allowed to take your training textbooks, whether they be the ones through the AAPC or if you're using Bucks or some other version. Leave these at home, tuck them away. You're not allowed to have them for the exam. In order to pass the exam, you need a 70% overall, or that means 70 questions correct. There is a breakdown on the AAPC website of what is on the CPC exam. So you can see here, there will be 4 questions specific to MedTerm. Now, that doesn't mean you only need to know MedTerm for those 4 questions. It means that there's only going to be 4 questions that are specifically testing you on MedTerm. There's going to be other questions where you're going to need to know the MedTerm in order to get to the correct answer for that question. 4 questions on anatomy, 3 are on compliance and regulatory, 7 questions that are just going to be testing you on the coding guidelines, either on ICD-10-CM or on CPT, things like modifier usage, ordering of the codes, things like that. 5 questions on ICD-10-CM. Now, that means 5 questions that are just going to be ICD-10-CM. There's going to be several cases where they'll test you on CPT and ICD-10, but there's going to be 5 specific questions that are just ICD-10 questions. 3 questions on HCPCS. 3 questions just on HCPCS codes. Again, you might see some questions that are maybe a case study that has a HCPCS code in it. But generally speaking, you could probably leave your HCPCS book at home and would still have a good chance at passing the exam because it's not heavily into HCPCS. This is the breakdown of what's going to be questioned on CPT. 6 questions on the 10,000 series, 6 on 20, 6 on 30, 6 on 40, 6 on 50, 6 on the 60s, 6 radiology questions, 6 path and lab questions, 6 medicine questions, 6 E&M questions, 4 anesthesia, and then 10 cases. Don't panic about the cases too much. Some people see the cases and they think, oh my gosh, those are cases. I'm going to have to code them from scratch. This is entirely multiple choice. For the CPC exam, those case questions are going to be multiple choice questions. When they say cases, what does that mean? Well, if you go through like the official curriculum with the AAPC and you have maybe one of their CPC books, and I think they may have some of these in the study guide as well. But if you look in them, they've got these long questions, and they call these long questions cases. So case basically means it's going to be like a longer operative note or a longer visit note of some kind. For some of the other certification exams, they might give you a case and ask you like 3 or 4 questions based off of that note. For the CPC, it says that they will have 1 question each for those 10 cases. Let's start with this question. It says, patient was seen in the office for a bilateral screening mammogram. What code should be assigned to the mammogram? This is a procedure, so we're going to want to be in our CPT book. So we can try starting out in the index and looking under mammogram. All right, so here's mammography, and we've got a couple of options here. We have computer-aided detection, localization with lesions, MRIs. This was a screen. So here we are, screening mammography, 77067. Now, this is the only option that we've been given. There's no range here, right? So we have a good amount of certainty at this point that this is going to be the correct code. You could at this point go, you know what? I'm going to take a little bit of a risk. I'm just going to say that that's the correct code and not double check it. But it's better that we do, right? Looking back on the question, 77067 is one of the potential answers on there. And if we look here, description 77067, screening mammography bilateral. which means since it already says bilateral in the description, we do not need the 50 modifier, including the CAD when performed. Some of the other options here, like the 7066, which would be our option B, that would not be for a screening, that would be for diagnostic. And the D, it has the RTLT, and again, this is bilateral, so we don't need a modifier to indicate that it's bilateral because it's in the code description. It's an inherent part of it. So our answer for this one would be our option A, 77067. Now on to our next question. This patient is seen for a laparoscopic cholecystectomy with intraoperative cholangiogram. What CPT code should be assigned for the procedure? Now, if you've ever watched any of my other videos where I've gone through case studies, you know that I say to not always use the index. You can just start with the section. So if this one we wanted to go into our digestive section and find the section for cholecystectomy, which would be under biliary, bile duct stuff, that is where we would find our cholecystectomy codes. The perk of doing that, of course, would be you'd already be in that section. You'd already be in the digestive section. You wouldn't have to go all the way to the index and then flip back to the digestive section anyway to get to those codes. But let's start over here with the digestive section. So this one, if we look back on the question that we have, this was a laparoscopic cholecystectomy. So we can see here a couple of things. It's laparoscopic. We're doing a cholecystectomy. And we have the cholangiogram. So those are our three key things we're going to be looking for when we're checking through this list in the index. So cholecystectomy, laparoscopic, and it's going to give us this range. But then, with cholangiography, and then we've got this range. We've got 47563, 47605, 47620, and then here we have the range. Typically, I would say you're going to have a better chance going by the laparoscopic because this might give us some opens. Not sure, but I'm gonna say let's stay over with these laparoscopic codes because we can see our option A is within that range, right? Our option B is within that range. We've just got one other. 47605 is our option C. Option D is 47610, which with exploration of the common duct, probably not that one. So we're ruling out option D. I would say rule out option D right away, but let's head over and see what it says in the section. Okay, laparoscopy, surgical cholecystectomy. And then this one does say with the cholangiography. So that one looks like the right one. 47563. What's R2? That's the one that doesn't have this added into it. And let's see just real quick, since we're right here, 605. See, 605 isn't in the laparoscopic section, so this would be an open code. It says for the laparoscopic approach to use this other code range. So in this case, our answer is going to be our option B, the 47563. Now, those were some relatively easy examples, but let's take a look at some that maybe aren't quite as easy. I'm going to ask you to just pause this screen and read through it, and then we'll go through and figure out how we're going to piece this together. With lesion removal, some of the things we have to look at is, was it cancerous or was it benign? Where was the location? What was the size? Depending on what it is, we might have to look at depth, but this is just a basic skin tag, basic skin removal. So we're going to start there. So one of the things we want to look at is, again, is this benign or malignant? So if we look here, this was a squamous cell carcinoma. We're going to want to know the type, the location, right? It's on the left forearm. And the size here was 3 centimeters. Now with lesion excisions, a simple one-layer closure is included. Intermediate complex are not. So this one here, if we look, it was an intermediate closure, which means we have to code that out as a separate CPT code. And then here's the length of that. Again, it was also on the left forearm. And then skin tags are not included in that. Skin tags are based off of not size or depth or location, but basically the number of skin tags that you're doing. Now, if you don't know this off the top of your head, because there's tons and tons of codes and we can't know everything off of the top of our heads, when you go and look up skin tags, it'll give you the difference of the two codes. The one is one quantity, the other is a different quantity. mammography. Or when you go to look up the lesion excisions, because in this case, we have the questions, the answers for the questions, potentially answers. So we could just start looking up some of the codes. Like I would start this looking at the 11603s or the 12032 codes and see where we are from there. So we have 5 skin tags, and we're just to separate the fact that this was not part of what was included in here. We're going to say, make sure we highlight this just to say this was the neck. This was not part of that squamous cell carcinoma stuff. Now, if we look at this, there's a lot of similarities, right, in the answer potentials. If we look at the ICD-10 codes, C4469, 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 C4469. So we don't even have to look at that because no matter what option we select, it's going to have C44629. It's going to have the L91.8. And, you know, if you see those C codes, if you think C for cancer, that's probably going to be our squamous cell carcinoma code, right? And then the L918 skin tag, right? So we have 603, 602, 603, 603. Some of these, it looks like all of them have the 59 modifier on them. We also have this 12032 in the mix. This one here, option C, does not have 12032. And then the 11200. So let's take a look. 11603. So since we're seeing that on 3 options, we need to look, okay, is there a difference between the O3 and the O2, and what is it? So if we look at our O3 versus the O2. So these codes are both from this section here: excision, malignant lesion, including margins, trunk, arms, or legs. And the forearms, of course, are part of the arms. So 11602 is 1.1 to 2. The O3 is 2.1 to 3 centimeter diameter. Now, if we look at that, remember we highlighted this section in yellow. So what's in our yellow section? It is the 3 centimeter. So that's the code size that we're going to go with for this. So here is our 3 centimeter. So that means option B is out. Now we also have to code for that intermediate closure, right? If you read through the guidelines for closures, it'll tell you that the simples are included, intermediates are not. So we want to code for that closure. And that's our green section there, intermediate closure 3.5. So here we want to make sure that we're in the right location, right? So scalp, axilla, trunk, and or extremities is the forearm and extremity, right? Forearm is an extremity. It says excluding hands and feet. That's a separate section. But the forearm is an extremity. Is it 2.5 or less? No. Is it 2.6 to 7.5? Yes. So 12032. So we want to make sure that we have that in the code. Since option C doesn't have that, option C is out. So let's take a look now at our difference between A and B. The difference here is this code here, the 11200, or the 11400 times 5. So let's look at our 11200. 11200, removal of skin tags, any area up to and including 15 lesions. And how many did we take off? 5. We took off 5. Now, if we were to look up that 11400 code, that would basically be for a 0.5 centimeter or less benign lesion, but we have a code specifically for skin tags. And this one, it says here, by any method of scissoring, sharp, ligature, strangulation, etc., etc. If we look at ours, it was removed with a surgical scissor. So that would be our correct code here, is that 11200, which means our answer here is option C. And those 59 modifiers, you'll see those a lot when there's lesions removed from other areas, because basically Medicare put this edit in place. They want to make sure that no one is double dipping on the same lesion, like saying, oh, we removed the skin tag, but it was also an excision of a lesion, so we're going to bill for both. So next question, patient with end-stage renal disease presents to the ambulatory surgery center for revision of his autogenous radiocephalic fistula that is needed for continued hemodialysis. What CPT codes should be utilized? Now, when I look at these potential answers for this, I see something in common. Do you see it? 3 of the answers start with 3, 6, 8. So my first thought is I'm not going to go to the index. I'm just going to go look at those 3, 6, 8 codes and figure out which one of those it possibly is. And if it's not them, maybe I'll look at 36904. So we have 825, 831, 832. 25 creation of arteriovenous fistula by other than direct arteriovenous anastomosis autogenous graft. Here we have thrombectomy. We didn't remove a thrombus. This one here, revision open arteriovenous fistula without thrombectomy. Okay. Autogenous or not autogenous dialysis graft. So there's some key things in there that are in here, right, too? This was for hemodialysis, right? Oop, I got my pen on instead of my highlighter. One sec here. So for hemodialysis, it's an autogenous radiocephalic. There's nothing in here about a thrombus. And also it was a revision, just like in the CPT code description. So in this case, this matches up to 36832. So for this one, that means our answer is option B. Now this one, again, I'm going to ask you to read through and then just pause or screenshot it. And if you look, we're going to be looking at the CPT and ICD-10 CM codes for this one. Now, when we go through and we verify everything that's in that procedural note, what we're going to come up with, and I didn't want to shrink it down into nothing into that little corner, but what we're going to come up with is that this is a placement of a feeding tube. Now, here's something where you are either going to need to know a little bit of med term or how to use some other terminology to look something up, or just know how to go to the digestive section and go to stomach and start looking for things that way. Because if you look up feed or you look up tube in the index, you're not going to get anything. What you are going to want to look up is nasogastric tube. Now, again, 43752 is one of the answers that we have. So if you want to go ahead and go, okay, well, I'm just going to pick that one right away. Like, it depends on how much risk you want to take as to whether you want to rule out the other options or not. But based off of the mapping here, it looks fairly likely that 43752 is going to be the correct code. So if we look at 43752, nasal or orogastric tube placement requiring physician skill and fluoroscopic guidance. 5.3 here, gastric intubation and aspirations therapeutic necessitating physician skill, including lavage if performed. So clearly our 7.2 is the correct one. So we can go ahead and rule out our A. And then what are we looking at differently from these components? Everything's 5.2. So what is the ICD-10-CM code? K3184. This one's K3184 with this E1143, which is a diabetic code. Anything that's in E11 or E10s, those are diabetes codes. I think E12, E13. So we could look at this right away and go, I didn't see anything on here about this patient having diabetes, and I would rule that one out as well. So really we're looking at, is it K3184 or R63.8? Considering the K was on the others, probably a higher likelihood that this is the right one, but we'll see. All right, so here we are, K3184 gastroparesis. There is a note here that says code first any underlying disease, such as, and includes the diabetes complications code. But again, this patient did not have diabetes. So we would be able to just code the K31.84 for the gastroparesis. I think the R63.3 is just difficulty feeding, which is not as specified as our gastroparesis. So option B, which is our 43752 and K3184. So when you're working through these questions, what is the fastest method for you? Is it going to be going to the index? Is it going to be going right to that specific chapter in CPT? Is it going to be assessing what the options are and then just looking up those codes? A lot of people find that faster. And I always say, you should really be looking at what your potential answers are before you're spending time lamenting over reading a long operative note or long case or question. Definitely let me know in the comments if there are other types of questions you would like to see me cover, if you found this helpful, if you think there would be a better format. I will see you guys in the next video, and until then, just keep on coding on.